Hello, this is Dr. Vomik. Welcome to my lecture series on Pediatrics, Endocrine and Metabolic series. Keeping with the theme of adrenal disease, today I'm going to talk to you about the Addison's disease in pediatrics. Now, as you know that I always like to know a little bit of the historical perspective of any condition. Thomas Addison was born in London, England, whom many consider is the father of endocrinology. He was born in 1793. In 1985, he described a syndrome which we call Addison syndrome. Now, Dr. Addison had a patient, a lady, who was severely anorectic, losing weight, asthenia, anemia, as well as severe hypotension. Dr. Addison was remarkably impressed by the bronze discoloration of her skin, and he did clinically suspect that this condition possibly related to the adrenal gland, and he was right. When this patient died, autopsy did show the destruction of adrenal cortex, and so he was right. He also diagnosed by reviewing the diary of a famous novel who wrote the novel about Sense and Sensibility and Pride and Prejudice, Jane Austen. She also had Addison's disease. What I was not aware of that, about 6 years prior to his description of Addison's disease, he also did describe pernicious anemia, which that time they used to call Addisonian anemia. And this is the skin coloration I have been talking, is that bronze discoloration or bronze phase of Addison's disease. So in pediatrics, the adrenal insufficiency or primary adrenal failure, the etiology is congenital adrenal hyperplasia. And that's account for about 70% of primary adrenal failure. In my lecture on congenital adrenal hyperplasia, I did mention in details how they present and including adrenal failure, so I will just be very brief here. The most common is 21-hydroxylase deficiency, which is 1 in 14,000. The other causes of adrenal insufficiency in pediatrics also is autoimmune adrenalitis. The autoimmune adrenalitis may be a loner or it could be associated with other autoimmune disease like diabetes, Hashimoto's thyroiditis, primary ovarian failure, vitiligo, pernicious anemia. And that is the reason why the patient who has type 1 diabetes, we keep on checking their thyroid function and thyroid antibodies just about yearly or every 2 years, because that association is very well known. If the diabetic patient has autoimmune thyroiditis, we also keep an eye on future development of adrenal failure or Addison's disease. There is only one genetic cause I want to discuss a little bit, and there is a slide on that, and that discussion will be very centered around that what you need to know about your exam and just a brief history about this condition. The genetic condition is adrenal leukodystrophy, ALD, which I will discuss a little bit in my subsequent slides. So what are the non-endocrine causes of Addison's disease? Well, it is infectious and others. By infectious one, unquestionably, is the tuberculosis. And if you want to consider the cause of Addison's disease worldwide, tuberculosis is still going to be very common. And in addition to that, the other granulomatous disease, like your sarcoidosis, HIV, could also give adrenal failure. But the one that we learn in the medical school, and that is the adrenal gland itself can be involved by an acute process like hemorrhage, severe infection or sepsis. Meningococcal infection used to be very common in the older days, and still it is not that common anymore. And these are the one was responsible for adrenal failure. The other condition at this time could be a tumor or metastasis of the tumor, and the chemotherapy or the radiation therapy we use to treat the adrenal gland. So the effect of the radiation and the tumor is still a cause, but is not as common as tuberculosis or autoimmune. Drug like ketoconazole could be responsible in adult mostly, but also in adult the one condition which is time-honored, what we call Sheehan syndrome. Sheehan syndrome is the postpartum pituitary necrosis or postpartum pituitary apoplexy, and that used to be a big problem, and still in a developing country with the difficult delivery, and this thing can happen. Now let me talk a little bit about adrenal leukodystrophy. This is a rare genetic condition. It primarily affects the central nervous system and adrenal gland. The incidence is about 1 in 17,000, but as I was reading, and I found there are some articles which says that it is 1 in 50,000, 57,000, but so I put the 1 in 17,000. So this is a very devastating condition, and in this condition there is accumulation of very high level of very long chain fatty acid in brain and adrenal gland, and the consequence of that is the failure of myelination of nerve. This is a X-linked recessive, and gene is located in X chromosome, and this is called ABCD1 or ATP binding cassette delivery D1 system, and this gene is actually give the instruction to make a protein called adrenal protein, which is crucial in transport in the very long chain fatty acid to the paroxysm. So when that does not happen, that accumulates in the brain, and which interfere with the myelination of central nervous system. So it is also in a way a paroxysmal condition too, and the fats build up and it's the demyelination of the nervous system and nerve occurs slowly and gradually. Those who are a little bit history buff or cinema, I would tell you that there was a movie in 1992 by Nick Nolte and Susan Sarandon, Lorenzo's Oil, and there they actually talking about their two sons who developed adrenal leukodystrophy. So that oil really is not very much used nowadays, but some people believe that before it develops a problem, before the disease become very prevalent, it might stop, not a stop, but slow the progress of the disease. And this is what you see in here is the total demyelination and intense bilateral parietal occipital signal, gray matter atrophy, and so this is a very typical finding of adrenal leukodystrophy. So just to complete the secondary cause of adrenal insufficiency, I'm just going to mention this, and I deliberately made those slides a little bit elaborate because if you just read through, you will get all the information. So it could be because of secondary involvement of pituitary gland by a tumor, by metastasis, and by any kind of injury that might result ACTH deficiency. Obviously, long-term corticosteroid use also produce adrenal suppression, and which I will discuss when we talk about, not at this lecture. There will be a separate lecture about management of hypothalamic pituitary adrenal axis suppression. The other cause is brain injury, traumatic brain injury or surgery, or radiation to the pituitary gland because of malignant tumor. And the secondary adrenal insufficiency is not associated with hyperpigmentation. The reason being that this is ACTH deficiency. So what gives hyperpigmentation? This is for our pediatric resident and medical student. Remember that when the ACTH is secreted, it comes in a very big fragment, and that's called pro-opiomelanocorticotropin. Pro-opiomelanocorticotropin. It is that melanotropin which secretes with ACTH give the hyperpigmentation of primary adrenal insufficiency or Addison's disease. So therefore, secondary one, you won't see hyperpigmentation. So predominant signs symptoms of patient with Addison's disease, and if you remember like this, hypothalamic pituitary adrenal axis. Hypothalamic is a hyperpigmentation and hypotension. Pituitary is also the hyperpigmentation, and A is anemia, asthenia, and hypotension. So therefore, fatigue, loss of appetite, severe anorexia, and they lose weight unintentional because they don't like to eat anything. There is abdominal pain, headache, dizziness, postural hypotension is very common, and obviously difficulty in concentration. Early on, the pigmentation is mostly seen in lips, gums, elbow, axilla, and around the areola, around the nipple and areola and tibial skin. But the whole face can be involved, as I have shown you the picture. I have seen my personal experience that two adolescent girl who was referred to our institution with the diagnosis of anorexia nervosa. They wouldn't eat anything and they lost weight, hypotension, and all these things. And both of them were found to have Addison's disease. So in adolescent girl, especially in girls, if somebody has this anorexia nervosa type of picture, the adrenal insufficiency must be excluded. As far as the investigation is concerned, if you do the CBC, you look at the cell rate because infectious cause like TB, cell rate will be high. You might see eosinophilia or lymphocytosis. And electrolyte is going to be very helpful. And they usually have low sodium and high potassium, as is the characteristic of electrolyte finding in acute adrenal insufficiency. Blood sugar will be low and there will be metabolic acidosis. Again, the time-honored measurement of AM/PM cortisol is very helpful because both AM/PM cortisol will be low, aldosterone will be low. However, plasma renin activity will be high since plasma renin controls the mineralocorticoid, and that's come from kidney, juxtaglomerular apparatus kidney. A TB skin test should be done, and the diagnostic one is ACTH stimulation test, which is a gold standard. CT scan, MRI of the pituitary gland, depending upon the cause that you are suspecting. The moment you have a suspicion or any initial lab which might suggest Addison disease, the patient should be referred to a specialist, endocrinologist. So, acute adrenal crisis, I just put this slide because I have discussed this one in congenital adrenal hyperplasia and acute adrenal failure. It is a medical emergency, no question about that. The patient usually present with dehydration, vomiting, fever, tachycardia, lethargic, and they are in shock. And the biochemically, the clincher to make the diagnosis is hyponatremia, hypoglycemia, and hyperkalemia. Hypoglycemia could be borderline, and metabolic acidosis also could be borderline metabolic acidosis, but as the time progresses, it could be very relevant. Now, management of adrenal crisis. This has been discussed again in CA's lecture. The first thing, doesn't matter whether it's adult or pediatrics, is volume expansion. And the volume expansion with normal saline the 20 ml per kg per hour as fast as possible. And hydrocortisone hemisuccinate 100 milligram per meter square you give initially as a IV push. And depending upon the blood glucose, which is usually low or may not be that low, but you start also 5% dextrose or 10% depending upon how low is the blood sugar with normal saline. However, I am going to give a scenario which I have faced myself and other. And the scenario is the patient has never been diagnosed as Addison's disease, just present in the emergency room with acute adrenal crisis. So no blood test has been done. So there is no baseline test that is available to you. So what can be done here is this. We need to do a ACTase stimulation test. So this is what is suggested and I have done, is that as soon as you start IV, obviously fluid will be going, and draw a blood sample for ACTase and the cortisol. And instead of giving hydrocortisone right away, give dexamethasone, which will not be measured as cortisol. So use that one and draw again another ACTase and the cortisol level after an hour of giving dexamethasone. Some people do it also 1 hour, 2 hours, and after that blood sample that you have obtained, now you can start giving hydrocortisone IV. Now, the dose of hydrocortisone we are talking about should initially provide the mineralocorticoid activity as well. So the patient obviously will be admitted in the hospital and should get either hydrocortisone continuous IV infusion or every 6 hours IV. As soon as the patient starts eating or can take anything, we can start giving mineralocorticoid. And most of the people will like to use hydrocortisone IV for about 48 hours. And after that, one can start oral corticosteroid and mineralocorticoid. The treatment is lifelong, and glucocorticoid and mineralocorticoid should be given, and it is managed best by a pediatric endocrinologist, and then when they grow up, they can go to the adult endocrinologist, and they can make that transition very efficiently. Now, always teach the family what is stress and what is the stress dose of oral steroid. However, if the patient is having vomiting or problem in taking anything by mouth, then all bets are off. You got to give intramuscular or intravenous. All family should be taught how to give hydrocortisone IM at home. And there should be a tag, the adrenal cortical insufficiency, just like diabetic patient has it, they will have. And so people will know once they go to the emergency room, physician can look at that and know that this patient has adrenal insufficiency, and that will expedite the treatment in the right way. And again, the family should be taught how to give the injection. However, managed properly, the longevity is normal, and this thing nowadays, that this is not a big problem. Once you make the diagnosis and properly manage, not a problem. And I'd like to thank you for listening to my talk. And as I have mentioned that if you know any medical student or resident or fellow that could be benefited, please refer them to my channel. And I have this, they have to type either Google type or YouTube search and they will find it. My next lecture will be to me is something the people have not heard that many times. I will talk to you about the management of hypothalamic pituitary adrenal axis suppression and how to taper the dose of the steroid. Okay. Again, thank you very much.